Welcome everybody. Let me introduce my PhD topic about the management of postoperative complications after third molar removal. My name is Eszter Hardi, and my vision as a PhD student is to improve the life quality of patients undergoing oral surgeries, and my mission is to find the best solution that alleviates patients' complaints after third molar removal. To achieve this, these are my current specific goals. I am investigating the effect of perineural twin mix injection, the kinesiology tape, and the different flap designs on postoperative complications after third molar removal. Let me introduce my first project about the effect of perineural twin mix injection in reducing postoperative complications in lower third molar removal, which is a systematic review and a meta-analysis. Why is this topic important? Because impacted lower third molars is found in 90% of the general population, and about 85% of third molar will eventually need to be removed. And after the surgery, in the first 7 days, patients have trismus, facial swelling, and pain. So our question is, how can we reduce these symptoms? Well, twin mix anesthesia is a novel technique for mandibular anesthesia. What is twin mix? It contains local anesthetic solution and dexamethasone. Addition of dexamethasone decreases the leukotrienes and prostaglandins and increases the pH, and it decreases the pain as short as the onset and prolongs the duration of anesthesia. So my aim is to assess whether pain, swelling, and trismus following surgical removal of the third molar can be reduced by perineural twin mix injection. So I compared the twin mix and the conventional anesthetic solution. My primary outcomes are swelling and trismus, and my secondary outcomes are postoperative pain score on local anesthetic injection, duration of soft tissue anesthesia, and latency of anesthesia. I did a systematic search in the main 3 databases with this final search key, and after the selection I have 8 eligible full texts. Let me introduce my results. My first 3 figures are investigating the effect of twin mix injection in reducing postoperative facial swelling in the first, 3rd, and on the 7th day. The facial swelling is one of the most important outcomes because it affects both the trismus and the pain. In this case, the swelling is obtained by subtracting the postoperative condition from the preoperative condition in millimeter. Here, the ideal situation would be 0 millimeter, which means there is no facial swelling. On the first 2 figures, we can see a quite high heterogeneity, and the explanation for this can be the different patients' characteristics and the subgroups, because the facial edema was measured on different face size, and based on this, we made 4 subgroups. We can say that the first and the 3rd days are clinically relevant because the facial edema was reduced with 20 and 25% in the twin mix group, and the 7th day is not clinically relevant. My next 3 figures are investigating the effect of perineural twin mix injection in reducing postoperative trismus on these days. The trismus is also an important outcome because it largely determines the life quality after the surgery. If there is a mouth opening limitation, then the eating, the speaking becomes difficult, and the maximum mouth opening becomes painful due to the muscle tense. In this case, the degree of trismus is obtained by subtracting the postoperative maximum mouth opening from the preoperative maximum mouth opening in millimeter. Here, the ideal situation would be also 0 millimeter, which means there is no mouth opening limitation. On all figures, we can see significant reduction, but only the 1st and the 3rd days are clinical, but neither day is clinically relevant. My next 3 figures are investigating the twin mix injection in reducing postoperative pain on first, 3rd, and on the 7th day. The pain is also an important outcome because it determines also the life quality. The postoperative pain was measured on this 10 points visual analog scale. In this case, the ideal situation would be 0 point, which means there is no pain. We can see that on these figures, the heterogeneities are quite high, and the explanation for this can be that the pain is a subjective feeling. We can say that the first and the third days are clinically relevant. The strength of this meta-analysis is that only RCTs were included, and the analyses were performed at multiple time points, and the limitation of this meta-analysis is that not the same references was used in case of swelling. In conclusion, the twin mix significantly reduces the patient's swelling, trismus, and pain in the first 3 days. And we can say that the twin mix is really useful because no additional injection is needed, and it contains low amount of steroids, so it means there is no complication and the cost is low. And the implication for research is that we should make more studies for better evidence, and we should follow up on each day, and we should use standardized measurement points, and we should include patients with similar patient characteristics. So I submitted my paper to Journal of Craniomaxillofacial Surgery, and now currently I'm waiting for their answer. So my second project is about the effect of kinesiotape as an aging therapy reducing postoperative complications in third molar removal, which is a randomized controlled trial. How I mentioned, after the third molar removal, in the first 7 days, patients have trismus, facial swelling, and pain. And our question is, again, how can we reduce these symptoms? Well, we always suggest the cryotherapy after the surgery because it produces vasoconstriction, controls bleeding, and decreases of tissue metabolism. In addition, a new technique appeared, which is the kinesiology tape treatment. How it works? It leads to the activation of mechanoreceptors by causing pressure, improving blood and lymph circulation. So my aim is to assess whether pain, swelling, and trismus following surgical removal of the third molar can be reduced by kinesiology tape. How I mentioned, I compared the kinesiology tape with different tensions and the placebo with no tension. My primary outcomes are swelling and trismus, and my secondary outcomes are pain, painkiller intake amount, kinesiology tape discomfort, and the quality of life. Yes, my hypothesis is that kinesiology taping with 40% tension is more effective than other tension and placebo in reducing pain, swelling, and trismus after mandibular third molar removal. It's really important that in each group the patient should use also ice packs, so cryotherapy. So now I'm working on the protocol, and finally we calculated the sample size, which is 82 patients per group. I would like to present my third project. I'm investigating the effect of different flap designs on patients' morbidity after lower wisdom tooth removal, which will be a systematic review and a network meta-analysis. The problem is the same. We would like to reduce these postoperative symptoms. While surgical removal involves the manipulation of both soft and hard tissue, and it is usually associated with a number of postoperative complications such as trismus, facial swelling, pain, wound dehiscence, alveolar osteitis, and parodontitis. So we can say that influencing factor can be the different type of incisions and the different flap designs. So my aim is to assess which are the best type of flap that can be used to reduce postoperative complications after lower third molar removal. So, how I mentioned, I will compare the different flap designs, and my primary outcomes will be also the swelling, the pain, and the trismus, and my secondary outcomes will be the alveolar osteitis, the periodontal condition, the wound dehiscence, and the operation time. After the title abstract selection, I have 94 articles. Now I'm working on the full text selection. So overall, currently I'm working on these 3 projects, and my plan is to finish my second project by April and my third project by January. And I'd like to thank you for your attention. A goal, and with a quote, a goal without a plan is only a dream.
Thank you. I have a question, actually 2 questions regarding your second project and your third project. I saw that on your third project you were investigating different kind of designs for flaps, and I was wondering if you have any idea, based on your preliminary research, which type of flap would be the best for preventing the complications. And also, I'm wondering, I saw that on your second project, you are choosing to use only the triangular flap, right, for the patients, if I'm right. And my question is if there is a reason for that, or it's just an arbitrary decision.
So can you repeat the real question?
Yeah, so basically the question was, why did you choose to use only the triangular flap on your
my second topic?
Yes.
Well, we usually use this kind of this triangular flap because I think this one is the best and the easiest for the resident and for the oral surgeon specialist. So I think this is the best one, but I would like to investigate it. Maybe we should change this protocol.
Okay, thank you.
We have time for other question.
I would like to ask regarding your first project, then about the pain and the visual analog scale. So in dentistry or maxillofacial surgery, is it considered clinically significant to have 1 point difference in the VAS scale? Because in anesthesiology, having an excruciating pain like VAS of 10 or nearly excruciating pain is almost the same. So do you think it's really clinically relevant to have 1 point difference?
Yes, I think totally, because after the surgery, patients don't sign the 10 point. They sign maximum 5 or 6 point. So I think in this case, 1 point can be relevant.
What's the difference? How could you describe the difference between 6 and 7?
It's a good question.
It hurts. It hurts a bit more. So I think it's not, in my opinion, or from an point of view.
It's a good question, but it's really hard because the pain is totally a subjective feeling, so it's really hard to measure it.